Good afternoon, everyone. My name is Morgan Gargiulo from the New England QIN-QIO, and I'll be your moderator for today's webinar, Chronic Care Management Services, Advantages for Your Practice. In case you didn't know, the QIN-QIO works with healthcare providers, stakeholders, and communities across New England on data-driven quality initiatives to improve patient safety, engage patients and families, and improve clinical care at the community level. Before we get started with today's webinar, I wanted to review a few housekeeping items. This call will be recorded for training purposes, and I'll provide you with details on accessing the recording at the end of the webinar. The phone lines are now on mute for the duration of the presentation. We will take questions at the end, and I'll instruct you on how to unmute your line at that time. You can also pose a question in the chat box on the bottom right side of your screen, and we'll review those questions at the end of the session. But make sure to send your questions to all participants so that we can keep up with the incoming questions. So for now, I would like to introduce our first speaker. Rachel Eichenbaum is a quality improvement specialist with the New England QIN-QIO. Ms. Eichenbaum works under the contract with Medicare in the 11th scope of work on the Everyone with Diabetes Counts task. Working with primary care practices all over New Hampshire, the goal is to improve the health of those living with diabetes. Rachel has worked with people living with chronic illnesses for 10 years in both the hospital and primary care settings and understands the necessities of chronic care management. So with that, I will pass it over to Rachel to get us started.
Good afternoon and welcome. Just to go over the agenda, during this webinar we will discuss Centers for Medicare and Medicaid strategies for improving healthcare quality. We'll give you an overview of the chronic care model and Medicare's chronic care management services, including the new billing codes introduced in January 2017. We'll also show you concrete ways to operationalize chronic care management and get paid for the work that you already do. Just to go over the objectives, we hope by the end of the webinar you will be able to describe the core attributes of the new Medicare Chronic Care Management codes and give examples of chronic care management activities that will count towards your chronic care management codes. That is a mouthful. So just to review again what Morgan already pointed out, but Qualidigm is the company that I work for. It's a Connecticut-based healthcare quality organization which is subcontracted with health-centric advisors to administer Medicare's 11th scope of work. This contract's goals are to improve the health of Medicare beneficiaries, improve quality of care, and reduce costs. The New England Quality Innovation Network Quality Improvement Organization, or QIN-QIO as we fondly call it, serves all 6 New England states. The New England QIN-QIO is your resource for Medicare initiatives, including the Quality Payment Program, Antibiotic Stewardship, Adverse Drug Events, Nursing Home Care Improvement, Million Hearts Campaign, Everyone with Diabetes Counts, Patient and Family Engagement, and Care Transitions. Don Berwick, a previous administrator for Centers for Medicare and Medicaid Services, brought the triple aim from the Institute of Healthcare Improvement, or IHI, to Medicare. The triple aim is a framework for optimizing our health system's performance by simultaneously accomplishing 3 critical objectives: improving the health of our population, and enhancing the patient experience, including the quality of the experience, access to health care, and reliability for health care, and reducing or at least controlling the per capita cost of care. The triple aim is also the cornerstone for the chronic care model and Medicare's chronic care management services. So this is a quote by Edward Wagner. The task of meeting the complex needs of people with chronic illness is the single greatest challenge facing organized medical practice. He recognized the need for care coordination and developed the chronic care model in 1998. At this time, 133 million Americans, or 40%, of our population live with a chronic illness. The chronic care model was designed to address this healthcare challenge. So what is the chronic care model? The chronic care model is a way of delivering quality integrated care in a variety of settings. Patients with multiple chronic illnesses manage, and I say that in quotes, their own diseases 90% of the time. Primary care sees them the other 1% of the time. So what can we do to support these patients when they leave the office? Using the chronic care model might be an answer. The goals are healthier, activated patients, satisfied providers, and cost containment. The chronic care model addresses the practice function, encouraging a move away from fee-for-service to team-based care. Team-based care spreads care tasks among the team members. This takes some of the burden off the provider's shoulders. This team goes into a clinical day prepared for their patients, following a care plan that they developed with the patient, family members, and the whole team. The care plan is a hallmark of the chronic care model, as well as the chronic care management services. This care plan takes into consideration who the patient is and what their preferences are. It also considers if their community supports their health efforts or creates barriers to better health. The care plan outlines how to best support the patient in managing their own illnesses. This coincides with the principles of the triple aim: population health, patient experience, and cost cutting. There are 6 elements to the chronic care model. The first element helps you focus on what is important to you, your organization, and staff. What is the composition of your staff, and how does your organization support the staff in accomplishing practice goals? An example of this element might be implementing staff huddles every morning to make sure everyone is literally and figuratively on the same page, prepared for the day, and daily tasks are assigned appropriately. Clinical information systems obviously refers to the electronic medical record and its ability to track and run reports on patients, and especially patients with multiple chronic diagnoses. It's important that your system can assist you in this task so you can have patient information available to ensure the patient is getting the care they need. Patients with chronic illnesses make decisions on their own every day, which is why I said they manage, in quote, they manage their illness. Any medical decisions should meet evidence-based practice guidelines, but also include patient and family preferences. Creating a care plan will be the framework for all decision-making. So again, here are the last 3 elements of the chronic care model. The chronic care model promotes a team-based approach. I already referred to that. But the team makeup depends on the patient's needs and goals. For example, one patient may have a social worker on her support team, while another patient may have a CBE or certified diabetes educator or nutritionist on his team. Task division is also important. Post-office visit and monthly check-in phone calls or emails are part of every care plan. These check-in phone calls or emails can be made by a nurse or an MA who are part of the patient's team, or the social worker or nutritionist. This team member will serve as the main contact, take care of referrals, do monthly check-ins, and address patient concerns. The second element on this slide is self-management support. Every patient manages their own health, some actively and some passively. The goal is to have patients become active managers of their health. There are a number of self-management programs out there. Some are taught by nutritionists and certified diabetes educators. Others are led by people from the community who have similar health struggles. Stanford's Diabetes Self-Management Program, a lay-led scripted workshop, is one of these programs. This program can help your patients become active self-managers who participate more fully in their care. And the last piece is to really point out the need for knowing your community so that you can pair your patient with appropriate resources from the community. I'd like to highlight the importance of the monthly contact phone or email check-ins with your patients. This study, conducted with 175,000 subjects, looked at the effect of telephone-based care management on medical costs and resource utilization rates. So subjects were randomly assigned to either usual support or enhanced support group. The enhanced support group received more phone calls than usual support. The subjects were identified by certain medical conditions and for their high healthcare utilization rates. The outcome of the enhanced support group, so the people that got many more phone calls or emails, were that patients spent less money at the pharmacy, close to $8 a person less, and had a 10% reduction in annual hospital admissions. So both of those are reduction costs for Medicare for your practice and the patient. Other benefits from telephone contact were improved patient satisfaction, clearer communication with their providers, less phone calls to provider offices, and better management of their illnesses so they became activated patients, and greater use of preventative services. Practices estimated the cost of this intervention was roughly $2 per person. Telephone support is an important part of the chronic care model and can be billed under Medicare's Chronic Care Management codes. A simple, low-cost intervention with really significant outcomes. So now I'd like to talk a little bit more about the chronic care management services. So in general, when practices adopt the chronic care management model, there are benefits for both provider and patient. Medicare has instituted codes to cover services provided for patients under the chronic care management model who have chronic multiple illnesses. These codes are under the Medicare umbrella called Chronic Care Management Services. I know it can be a little confusing between a chronic care management service and the model. You can see from the study I cited, a simple intervention such as check-in phone calls, an integral part of a care plan, can make a difference in patient satisfaction, cost containment, and healthcare utilization. You may already be offering chronic care management services. Tracking and billing for these services may be your next step. Susan Whittaker will be talking about the specifics of how to bill for what you may do later in the talk. I have some quick slides on why Medicare is concerned. Here's some statistics to illustrate that. 68% of Medicare beneficiaries have 2 or more chronic illnesses, while 36% have 4 or more chronic illnesses. This is a look at the mortality rates for the most common chronic illnesses that Medicare beneficiaries have. Heart disease, cancer, stroke, and diabetes are the top 4 diseases that affect Medicare beneficiaries, and the top 4 ways we lose our Medicare patients. These 4 chronic illnesses have high monetary costs and cost lives. Using chronic care management services can reduce monetary costs, and your patients live healthier, longer lives. So again, I've talked about healthcare utilization. So Medicare costs are highest for beneficiaries with multiple chronic illnesses, which really makes sense. Healthcare utilization and costs both increase the more chronic illnesses a beneficiary has. Again, this is sort of the same look at a per capita yearly cost for Medicare. As the chronic conditions increase, so does the cost. Now I would like to turn the talk over to Yvonne La-Garde to give the patient and caregiver perspective on care management. Yvonne La-Garde has a master's degree in special education and behavioral psychology. She was the CEO of a company that provided 24/7 care to adults with developmental disabilities for 30 years. In both her personal and professional life, she has experienced the ineffectiveness of chronic care management in the healthcare system. Go ahead, Yvonne.
Yvonne, make sure to unmute your phone by pressing #6, and then make sure you haven't also manually muted your phone line.
Hello.
Hi, we can hear you.
Hello. I'd like to personalize chronic care management by introducing you to my brother, who's fondly known as Frenchie. In September 2015, Frenchie, who's a quadriplegic since 1987, was working full-time, driving to and from work. He maintained his home independently and supported his wife as the primary income earner. In October 2015, Frenchie was hospitalized. Some kind of flesh-eating bacteria had entered a small bed sore on his buttocks. The bacteria infected his blood and his bones. A girdle stone procedure was conducted to remove the upper part of his right femur, and it left a gaping wound the size of a grapefruit. At the time of surgery, the surgeon told the family that nothing else had to be done to the wound, so our expectations was that the wound would heal. While at the hospital, Frenchie acquired 5 additional level 4 wounds, given the nursing staff were focusing on his infection and not managing his quadriplegia. The nursing staff neither repositioned him nor provided a bed that would relieve the pressure on his wounds. As a result, Frenchie went into the hospital from home with a small bed sore and left the hospital and went into a rehabilitation hospital with 6 wounds. He was discharged from the rehabilitation hospital in December 2015 and was supported at home by family and visiting nurses, but there was no chronic care management plan in place, and his health continued to fail. In February 2016, Frenchie had difficulty breathing. He was hospitalized again, was diagnosed with COPD, and placed on oxygen 24/7. He returned home again, no chronic care management plan in place. At this juncture, he managed his bowels independently. He catheterized himself independently. At home, he got an additional wound in his groin, and his visiting nurses agency recommended going to a nursing care facility because his health care had become more complicated. The staff at the nursing care facility did not know how to manage his care. His wounds did not heal but got worse. His blood protein levels were well below normal, which as you know, really impacts healing. He lost weight at 6 feet 2 inches tall. He only weighed 107 pounds. He could no longer catheterize himself and had a Foley catheter. After passing out on a commode at the nursing care facility, he was again sent to ER. While there, he had a G-tube inserted. In early 2016, Frenchie was on oxygen 24/7, had a Foley catheter, was on a feeding tube for daily nutrients and protein. Nursing staff provided daily medications, which he had previously taken independently. He was gradually losing his independence. Chronic care case management could have ensured a better transition between the nursing care facility and the hospital, ultimately providing Frenchie better and safer care. In March, he was transferred to a mental care and rehabilitation hospital where he was diagnosed and treated for osteomyelitis, which was noted in January but went untreated, and finally his wounds started to improve. Consultation with occupational therapy staff and research by family resulted in the family renting an air fluidized bed, which proved to release pressure on his wounds, negating the need for continual repositioning. And this highly specialized bed played a crucial role in his improved care and wound management. Blood protein levels of 17 were up from 3. Focus on nutrition, 2 feeding, helped him gain weight. He weighed 124 pounds, up from 107. His family advocated for him to start lifting weights to maintain upper body strength so that he could transfer independently into a wheelchair. His wounds had healed. By June 2016, he was well enough to be transferred to a skilled nursing facility where he started to make slow, gradual progress. He continued to work full-time, bedridden, and increased his weightlifting regime. By Christmas 2016, he could lift 2 12-pound dumbbells overhead. He had increased his muscle mass in his chest and arms, and he now weighed 153 pounds. His blood protein levels were normal. In November 2016, we were very excited. His surgeon at Brigham and Women's Wound Care Center was prepared to do flat surgery on his original wound in early 2017. But unfortunately, he was hospitalized again late November 2016 because he had difficulty breathing. The hospital staff lacked knowledge regarding how to operate the bed designed for patients with wounds. The result, the middle panel of his bed was not inflated, and Frenchie was lying on a hard surface, and he got a new large wound in his sacral area. Consequently, surgery that was recommended in 2016 was sent back 6 months, and his health regressed again. As a quadriplegic patient, the nursing staff had difficulty keeping his buttocks area wounds clean and clear of infected material. The wound in the sacral area would not heal due to infection, and my brother's COPD got worse as he got more and more anxious. He was readmitted to the hospital in February 2016 for difficulty breathing and abdominal bloating. Again, this is where chronic care case management would have saved Frenchie from getting an infection and saved another hospitalization. The family requested a consult with a gastroenterologist who recommended a colostomy, and it was anticipated that this procedure would keep the sacral area cleaner and reduce the chance for infection, promoting better wound management. The colostomy surgery was successful. In March 2017, my brother was readmitted to a skilled nursing facility. He continued to receive daily wound care at that facility with instructions provided by a wound care center at a Southern New Hampshire hospital. At the hospital, wound care nurses inspected and noted changes in the depth and size of each wound and replaced dressings weekly. And as needed, a surgeon debrided his wounds. In addition, every 6 to 8 weeks, Frenchie visited a plastic surgeon at Brigham and Women's, and that surgeon was directing his care management and will determine when he's a candidate for flap surgery to close the wound. Finally, have a care management plan in place, which is shared between 3 different hospital settings, Frenchie and his family. A year ago, my brother weighed barely 100 pounds. Today he weighs 155 pounds. He continues to build his upper body strength by doing weight training 3 to 5 days a week. His progress has been significant. When he started a year ago, he could only lift 3-pound weights. He now lifts 18-pound weights. His blood circulation has improved. His COPD is under control. He's no longer on oxygen, and he's currently able to sit in a wheelchair 3 hours a day, and he's been outside in the air for the first time since November 2015. During this 18-month ordeal, my brother has continued to work full-time using a laptop computer from his bedside. Working has kept him mentally engaged, but it's also allowed him to support his family and pay for his health insurance through his employer. And despite all the experience, he's maintained a positive attitude. To prepare for the surgical procedure, an action plan has been developed in collaboration with the family and the medical staff. And at a recent visit, his trauma surgeon said it was reasonable to expect his wounds would heal sufficiently so he can have flap surgery sometime this summer. Furthermore, the doctor thought he'd be able to return home and resume his normal life prior to the events of October 2015. Sadly, my brother has run out of hospital bed days, and he's spending down his retirement to pay for continued hospital care. In my brother's case, better chronic care management would have reduced hospital admissions and readmissions, provided him better, safer care. It would have lowered the cost of care for my brother and the health care. It would have promoted effective communication and coordination of care to ensure much better transitions between settings. Hopefully, in spite of many obstacles to Frenchie's chronic care, he will make progress and go home in the fall of 2017. This is what we're hopeful for. And thank you for listening to my story.
That was great, Yvonne. Thank you very much. So now we're going to pass it over to Susan Whittaker. She's a senior program coordinator for the New England QIN-QIO, working to support Maine practices through the Macro MIPS and Surge Quality Payment Program. Susan has extensive experience in physician medical services delivery and worked with coding and documentation compliance before beginning her work with the QIO. So, Susan, I will pass it over to you. Yvonne, if you can pass the ball to Susan, please. And there you go, Susan. So take it away. Susan, make sure to unmute yourself. Make sure you press pound 6 and then unmute yourself.
I got it. Can you hear me now?
Yes, we can. Go ahead.
Oh, okay, thank you. Hello, everyone. Chronic care management is a win-win solution for patients and providers. It supports the shift from a fee-for-service care model to a team-based approach for patients who are chronically ill. In this part of the presentation, I'll refer to chronic care management as CCM. We'll look more closely at the value of CCM and who qualifies to receive it. We'll discuss what constitutes billable CCM actions and how they're tracked and charged at the end of the month. References to physicians is meant to include all non-physician billing practitioners that are eligible to provide chronic care management. This slide lists ways patients benefit from chronic care management. They receive a dedicated healthcare team within your practice, a personalized care plan, focused support between medical visits, better care transitions, and because patients have a copy of their care plan, they have an increased ability to self-manage their illnesses. The practice benefits by being able to bill for the time spent rendering non-face-to-face services that you and your staff usually provide to chronically ill patients. For complex patients, providers, except for those in rural health centers and federally qualified health centers, may also bill a comprehensive assessment and plan, HCPCS code GO506, which we'll talk more about in a few minutes. Chronic care management simplifies care coordination and transition by creating a mechanism by which to track and manage all non-face-to-face care in one convenient place in the medical record. Because the care plan is created with the patient and or caregiver engagement and is available to staff, CCM supports physician work and supports adherence to those care plans. Patient practice communication is increased, and CCM sustains and grows your practice by improving team-based care and adequately meeting patients' needs between visits. Who's eligible to receive CCM? Patients with Medicare. That includes Medicare Part B, also known as Original Medicare, most HMO Advantage plans, and dual eligible patients, which are those with Medicare and Medicaid. Some commercial insurances may also cover CCM. The diagnostic criteria includes patients who have 2 or more chronic illnesses that are expected to last at least 12 months with risk of exacerbation, decompensation, functional decline, or death. Here are some of the chronic condition examples. Please keep in mind that the chronic condition would need to meet the criteria on the last slide and that it would be expected to last at least a year with risk of decline or exacerbation. End-stage renal disease is not mentioned here because it has its own set of billable monthly management services. All clinical and office staff may render chronic care management under the direction of the billing physician. Medicare does recommend a go-to person, but all staff may participate in chronic care management. Any non-face-to-face services by the billable physician or those covering are also included in the monthly CCM documentation. Providers that may bill Medicare for chronic care management include physicians, nurse practitioners, physician's assistants, certified nurse midwives, and clinical nurse specialists. Until this year, an initiating visit was required before beginning CCM. However, as of January 2017, established patients seen within a year may begin CCM services when they consent verbally and a care plan is established for them. New patients, or those not seen within a year, still require an initiating visit, so providers have an opportunity to update the problem list and history, assess chronic conditions, and create the care plan. Some complex patients may need a comprehensive assessment that goes beyond the usual work of an evaluation and management service. An evaluation and management services is defined as an office visit or annual wellness visit, for example. In the cases of a complex patient, HCPCS code GO506 may be billed in addition to the evaluation and management code. Excuse me. unless the patient is in a rural health center or FQHC. The patient consent, which helps to prevent duplicate services among the patient's providers, may be verbal, but must be documented in the medical record. This consent is active until the patient withdraws from services or changes billing providers. Codes Demystified. As previously stated, GO 506 would be charged when a comprehensive assessment is necessary and takes time beyond an office visit, AWV, or other E&M service. Documentation of GO 506 includes a status assessment and plan for each chronic condition. A copy of the care plan, whenever it is created, is given to the patient and or caregivers. Please be aware that GO 506 is an add-on code, so must be billed with another E&M service and would not be billed as a standalone code. I would just like to say here that I'm a very big fan of annual wellness visits. They're not only a great time to address screenings and quality measures, and AWV is an excellent opportunity to identify and funnel applicable patients into chronic care management. The approximate non-facility reimbursement rate for GO 506 is $64. Non-facility refers to the rate that's paid to physician practices that are not provider-based hospital practices. Therefore, this rate will vary by region and by practice affiliation. When CPM is initiated, typically a monthly episodic or flow sheet type of encounter is created in the medical record in which the care team documents all non-face-to-face care management for 2 or more chronic conditions. CPT code 99490, effective in January 2016, is the basic code charged for at least 20 minutes of non-face-to-face services. Provider involvement is part of CCM. Therefore, approximately 15 minutes of billing practitioner work is assumed for this service. Practitioner work is defined as directing staff, personally performing CCM actions, updating the care plan, and or changing orders. 99490 renders about $43 in reimbursement. Please note that once 60 minutes of chronic care management is reached for a patient, you would use the code on the next slide, unless you're in an RHC or FQHC. They are limited to this code only, no matter how much time is spent in CCM. Effective in January 2017, Medicare created complex chronic care management to cover extended non-face-to-face patient management. This code covers at least 60 minutes of CCM, 26 minutes of which assumes billing practitioner work. I'd like to emphasize that assuming the minutes of practitioner work is an approximate time, and there's no need to track that specifically. However, this does act as a reminder for physicians to also document their non-face-to-face actions in the CCM encounter. Moderate to high medical decision-making is expected for these patients. This is fairly easily demonstrated because according to Medicare's table of risk, moderate to high medical decision-making includes management of 2 or more chronic stable illnesses. Reimbursement rate for this code is approximately $94. CPT code 99489 is an add-on code used with code 99487 on the previous slide. This code reflects each additional 30 minutes beyond the initial 60 minutes. For example, if 2 hours of CCM was rendered to a patient in 1 calendar month, their CCM charge would be 99487 and 99489 times 2. Reimbursement rate for each additional 30 minutes is about $47. The approximate reimbursement rate for the 2 hours of care in this example is $188. This is a coding summary of all applicable codes and approximate reimbursement rates. Again, the rural health centers and federally qualified health centers would only use the 99490. Now let's move on to the documentation necessary to support chronic care management billing. The comprehensive care plan would include the problem, prognosis, measurable goals, symptom management, interventions, community services plan, and the review date, which can be monthly, annually, it can be at each face-to-face visit. It is whatever the physician thinks is necessary. These actions may be included in CCM service time, coordination of community-based services, patient practice communication. This would include the monthly check-ins that Rachel referred to in her presentation, medical review and lab review, which would also include any other tests or imaging and cardiac tests, medication management, and that would include medication reconciliation in the EHR as medication changes are made, coordinating care with other providers, and disease and care plan updates, which includes the time it takes for physicians or those covering the patient to make changes to the problem list and medical history. For example, if a patient calls with a new problem, such as nausea with chemotherapy treatment, and a new medication is given, the time it takes to discuss this with the patient, process the prescription, and reconcile the medication and problem list would all be included in CCM. You would document all places necessary in the EHR to update the patient's case sheets, and then you would add a summary and time spent to the CCM encounter flow sheet to get credit for that non-face-to-face care. Part of the documentation summary for CCM actions are the date, who performed the action, and the time spent doing so. Most EHRs will date and signature stamp for you. However, be sure to add the time spent performing the action. As mentioned, through the chronic care management process, the problem list, medication reconciliation, and health history is all kept up to date, which really benefits your patient and saves you time in any acute situation. To summarize the billing process, an encounter is created each month for tracking CCM documentation. At month end, the total time spent is calculated and the appropriate CCM code or codes are selected and billed. You may bill before the end of the month if CCM services are completed in the event of a patient move, admission to the hospital, or due to death. A patient request to discontinue services is effective at the end of the present month, so you may continue to include non-face-to-face time within that month. The diagnoses used are the chronic illnesses from the CCM care plan. The place of service used is the place the billing practitioner would normally render a face-to-face service with the patient. For example, office, assisted living center, or nursing home. Please note that CCM may be billed for skilled nursing facility and nursing home and assisted living patients who are not in a Medicare Part A covered acute patient stay. And lastly, CCM services may not be billed with transitional care management, home health supervision, hospice supervision, end-stage renal disease services, prolonged E&M services, or another provider's chronic care management. For more information, these resources are available from CMS. The first link brings you to CMS's Chronic Care Management resource page. The second is a link to the CCM changes for 2017. And the third link gives you the current CCM fact sheet, which is a very valuable document. It sort of summarizes everything I've spoken about today. Thank you very much for your attention. I look forward to any questions you may have. And now I'll turn the presentation back over to Morgan.
Thank you, Susan. Well, as you guys can see on the screen right now, we have a list of all the contact information for all the ladies that presented today, so you can follow up with them should you have any questions. But if you'd like to ask a question now, you can press #6 on your phone to unmute your line and ask a question, or you can type it into the chat box on the right side of your screen. And just ask if we can get a copy of the slides. The slides are located on our website. I put that link in chat earlier, but I'll go ahead and do it again. So you guys can go to our event page on the website to download the slides, and the recording and transcript will also be there in a few business days. Linda Kurtula, one of our diabetes task folks here in Connecticut, put a couple of comments into the chat box that I would be happy to read to you guys. She said the mortality rates in the pie chart due to diabetes are probably underestimated, as often diabetes is a significant risk factor for heart disease, stroke, and is being associated with higher risk of cancer as well as dementia. Emphasizes the need for early detection, medical management, and self-management education, both by CDEs and the DSME program. And then she also said, how would CCM reimbursement apply to reaching out telephonically to patients who are at a high risk for multiple readmissions due to uncontrolled diabetes? If you guys want to answer that one, or I can continue reading her comment. It's up to you.
This is Susan. I'm all set to answer the second question about the CCM reimbursement. As long as the patient had consented to receiving CCM services and had another co-condition along with the diabetes, then that would definitely fall into chronic care management services.
Perfect. She then also stated, or the question afterwards, that the outreach would include having patients reporting blood sugars, levels of adherence with insulin oral agent doses, then licensed staff adjusting doses over the phone under the direction of a provider proactively before glucose levels become uncontrolled.
Yep, all those services, they're actually perfect for chronic care management. That's pretty much what it's designed for, is to take care of those services.
Excellent. I don't see any other questions in chat right now. Are there any questions on the phone? Again, if you would press #6 to unmute your line, you can ask a question.
Hello?
Hi.
Hi. Hi, Morgan. Thanks for reading my comment in the chat. This is Linda. And I just had an additional question about, do you know of any practices that have used this model in a diabetes care center, or a place that manages just people with diabetes, and how successful that's been?
This is Susan. I have not had experience with that, but would these people you're not their PCP, correct?
Correct.
Yeah. If you're just handling their diabetes, I don't think the chronic care management services would pertain to that because you're managing, as I understand it, just the diabetes, and this is for managing 2 or more chronic illnesses. So it's more geared toward PCPs or toward specialists dealing with an episodic illness.
Okay. And are you aware if it has been used in primary care practices, like that telephonic outreach piece, and how effective that's been with diabetic people?
I have not had that experience. I don't know if, Rachel, if you've had any experience with that.
I haven't had experience with it. I know I can definitely look up, do some research on that for you, Linda, and send you information about it. I know that the chronic care model is being used by practices, but I need to do some research.
Yeah, and we can do that together, Rachel, because we're colleagues, and I don't want to do more work. But, I worked for the Joslin Diabetes Center for several years, and we did this kind of outreach, and it was really effective in terms of, identifying the people who had, high depression, anxiety, psychosocial issues, and we did outbound calls to them, and, did some med reconciliation, found out what they're actually taking, what their blood sugars are, and we're actually, really able to kind of proactively help people stay in control, and if they're uncontrolled, adjust their medicine to help keep them out of the hospital. So, as a QIN-QIO, that might be something, we want to encourage in primary practices if they have CDEs or APRNs that are skilled at doing that. So just an idea.
I agree with you, Linda. I think, it sort of points out the issue of the flexibility of the care plan. Someone who was struggling with psychosocial issues like depression would probably have a social worker on their team also and be able to inform the patient about community resources. So it goes beyond just the phone call, but also that support would be in there.
Yeah. Great. Thank you.
Do we have any other questions on the line? Again, it's #6 to unmute your line to ask a question. All right, ladies, well, I'm not seeing anything else popping up in chat. Is there any last-minute things you guys would like to say to the group before I close out the session? Alrighty, I will take that as a no. So thank you everyone for attending today's webinar. Just a few last-minute announcements before we end today. As you can see, I can't get my computer to work. As you can see from the slide on the screen, we're now on social media, so please connect with us on Facebook and LinkedIn for the latest resources, webinars, and other offerings from the New England QIN-QIO. When you close out of the webinar, the evaluation will automatically pop up on your screen. If you could please fill that out, we would greatly appreciate it. If you don't have time to fill out the evaluation right now, or you're currently sharing a computer with someone else, you will receive an email tomorrow containing a link to the evaluation. That email will also contain a link to the event page on our website where you can find the PowerPoint presentation as well as the recording and transcript that will be added within a few business days. So thank you again for attending, and